Hello, my Russian friends. This is Chen from Cleveland Clinic. This coming Friday, we will talk about lymphatic surgery. We will go over the currently available lymphatic reconstruction procedures, including LVA, lymph vessel transfer, lymph node transfer, liposuction, and Charles procedure. After a general overview, I will talk about my take on several controversies, such as when to do what procedure, vascularized lymph vessel transfer versus lymph node transfer, when to do LVA, and whether lymphatic surgery can cure lymphedema. So we will cover multiple, currently most debated topics. And also remember to bring your challenging questions. Let's make it a discussion and let's have fun. I look forward to meeting all of you on Friday.
So hello everyone. We're still waiting for Dr. Chen to be connected. So we will wait a couple minutes.
Oh. Hello. Hi. Give me.
Yes, hello, Dr. Chen.
20 seconds. Sorry. So sorry about it. Hello, everyone.
Okay, we can now start, right?
Yes, please.
So, yes, my name is Georgi Nazarian, and I want just to present that I'm a hand surgeon, microsurgeon working in a hospital number 20 in Moscow, and head of Reconstructive, and in Russia it's a national holiday, so-called Russia Day, and we wanted with Dr. Chen to have his talk about supermicrosurgery and microsurgery. Dr. Chen is well-known key opinion leader in supermicrosurgery, and he is a clinical professor in plastic surgery and head of regional microsurgery and supermicrosurgery, co-director of a center for lymphedemic research in a Cleveland clinic. We will have your talk. Translate them into a question which will be in English. You will read it and answer simultaneously also. So, Dr. Chen, please go ahead.
Okay, so my lecture is 22 minutes, and for efficiency, I have pre-recorded the lecture, and I will come back on live for question and answer session when we are done. I'm going to go ahead and share the screen now. Okay, can you see my share screen?
Yeah. Yes.
Yep. All right, so we will go ahead and get started to talk to you about key concepts in current lymphedema surgery. So you know I'm passionate about this topic. There's a lot to talk about, and I only have 20 minutes. So let's get started. I have no disclosure. So I'm going to go through this fairly quickly, and I will fly through multiple subjects. That simply takes a lot more to explain, so please feel free to ask me to clarify things during the question and answer session. So before we start treating anything, we need to cinch the diagnosis. And even though it's very, very appealing to use a circumference measure to reach diagnosis, to make diagnosis of lymphedema, but I would highly recommend that we don't do that, because a circumference measurement using it as a diagnostic modality has a very poor sensitivity and very poor specificity, and has a high inter-rater and intra-rater error. You can measure 5 times, you get 5 different measurements. And to me, it's not acceptable as a diagnostic test, because these are all the other conditions that mimic lymphedema. And if all we have at our disposal is a tape measure, it's very difficult to properly rule out or rule in all of these other conditions. Therefore, I recommend image-based diagnosis. Not lymphoscintigraphy, but ICG lymphography. So lymphoscintigraphy used to be said as the gold standard. I agree, it was the gold standard of the 20th century, but we're now in 21st century. ICG lymphography, in my opinion, is far superior. So not only that we can diagnose the patient with lymphedema, we can also stratify the disease severity. depending on the type of patterns that are seen on the ICG lymphography. So following injection intradermally, the ICG gets rapidly picked up by the intradermal lymphatic capillaries and gets sent down through lymphatic perforators down to deeper lymphatics until we get down to the subfascial lymphatics. When I say subfascial, I'm referring to the superficial fascia. And these many people call collectors. So when we see linear pattern, what we're seeing are the collectors. When there's an obstruction, then the ICG starts to get routed through collaterals, and that's manifested as the splash pattern. When it gets reflux to a more superficial level, then it's called stardust. And to an even more superficial level, then the patterns, the reflux patterns start to merge together, and all you see is a big patchy area of reflux called diffuse. So depending on the patterns and also the distribution of these patterns, we can stage the severity of disease. And when you perform ICG lymphography, it is important that you perform a delay scan. You can see in this patient, right arm is healthy, left arm has lymphedema. Immediately following injection of ICG, you see no dermal bacterial pattern. You start to see something later on. In about 5-10 minutes or so in this particular patient, you saw a lot more at 2 hours, even more at 4 hours, still more at 6 hours, and then it remained relatively stable. We call it the steady state, and until the patient reached the regression point at 12 to 14 hours. At that time point, the signal started to recede. So this means that you need to do a delay scan between 6 to 12 to 14 hours. So point of plateau and point of regression at 12 to 14 hours. Same thing for lower extremity, as in this patient, you can see this patient plateau, and we can properly stage the patient at 6 hours out. And so now we have a diagnosis. We also know the severity of lymphatic injury. Now it's time to determine whether the patient has fluid or solid predominance of lymphedema. It's actually pretty easy and straightforward. After having seen enough patients, just looking at the patient, we know whether the patient has fluid or solid predominant disease. But what we look at are whether there's presence of pitting, and very importantly, the reversibility of swelling. When the patient says, my leg looks normal in the morning, but towards the end of the day, it gets very swollen. But in the morning, after a good night's sleep with the leg elevated, it reverted back to normal in the beginning. That means this patient has fluid predominant disease. And typically for these patients on ICG lymphography, they show relatively mild injury. As compared to solid predominant state, these patients have non-pitting lymphedema. They're characteristically non-reversible. The bulkiness is not reversible. Obviously, because lipodystrophy and subcutaneous fibrosis don't go away overnight, just like swelling would. And these patients typically have advanced injury seen on ICG lymphography. So if you're still not sure, you can technology can help. You can get bioimpedance spectroscopy, which would quantify the amount of fluid, or you can get an MRI and distinguish whether the bulkiness is mostly fluid or mostly solid disease. If you're interested in reading up on how to use bioimpedance for this purpose, please refer to our study. And so now we know we have the information that we need to start to treat the patient. We have a diagnosis, we know the severity of lymphatic injury, and we also know whether the patient is solid or fluid predominant. So now we're ready to treat. The first question is, do we treat with surgery or we treat without surgery, surgical or non-surgical treatment? So there's a lot to be said about how to reach that decision. Basically, in my opinion, complex decongestive therapy and surgery are two equally effective but very different treatments. And there are pros and cons associated with each. So which one a given patient should go with is dependent on many factors, and patients should be involved in the discussion. And if you have questions about this, please ask me during the Q&A. So assuming that, well, we're surgeons, assuming that the patient wants surgery. So if the patient wants surgery and we have decided we're going to offer surgery, what procedure should we offer? So these are all the procedures that are currently available, from LVA to lymph vessel transfer, lymph node transfer, liposuction, Charles procedure, and then, of course, the newest supermicrovascularized lymph vessel transfer. This is not lymph node transfer, but lymph vessel transfer. This is also in the sequence of least invasive to the most invasive. In general, we try to offer the least invasive procedure to get the job done. This is a comparison between vascular surgery, cardiac surgery, microsurgery, and supermicrosurgery. So when I say supermicro, LVA, supermicro lymph vessel transfer, this gives you a scale. And this is my algorithm going from stage 0 disease to fluid predominant disease to late fluid predominant disease to solid predominant disease to fulminant disease. There is a procedure for every disease severity. Of note, I rarely need to resort to lymph node transfer. In my practice, the lymph vessel transfer has almost completely replaced lymph node transfer. So the key concept is to do LVA whenever possible. Not only that it's the least invasive procedure of all, but also because it fails well. So supermicro LVA, I believe everybody has heard of it, or many of you might have even the experts already in this procedure. But for those who are new to the concept, the LVA basically involves connecting lymph vessel to vein, so the lymph can return through our circulatory system through the veins. So I map the lymph vessels and I map the veins. As you can see here, the black line, red line, and blue line represents lymph vessels in different lymphosomes. So this was mapped via a mapping lymphography. This is different from the diagnostic ICG lymphography that I just explained to you. Mapping ICG lymphography is performed differently with much more injection sites. And once I have all the lymph vessels in different lymphosomes mapped out, I map out the veins, and the veins are those dotted lines, and then I plan my incision. We won't have time to watch this video, but I'll just play a little bit. This is an end-to-side anastomosis, and the blue line represents lymph vessels in different lymphosomes. So this was mapped via a mapping lymphography. This is different from the diagnostic ICG lymphography that I just explained to you. Mapping ICG lymphography is performed differently with much more injection sites. And once I have all the lymph vessels in different lymphosomes mapped out, I map out the veins, and the veins are those dotted lines, and then I plan my incision. We won't have time to watch this video, but I'll just play a little bit. This is an end-to-side anastomosis. And okay, so many people said when there's no linear pattern seen on the ICG lymphography, LVA is contraindicated. I disagree with that statement. LVA remains feasible even in the absence of linear pattern. However, this is also when the lymph vessel transfer should be considered in my protocol, because at least in theory, lymph vessel transfer should work better because now the lymph vessels are mostly damaged and they wouldn't work as well in LVA. However, LVA would still work. So that involved, this would require a more involved discussion with the patient. So this is lymph node transfer, and this is lymph vessel transfer, because the flap is now super thin. So there won't be a contour deformity as in lymph node transfer. So in my mind, lymph node transfer, even though it works great, it's certainly not restoring form. In fact, we would be deforming the patient. So you can think of lymph vessel transfer as the super micro version of lymph node transfer. In my mind, it's lymph node transfer 2.0. So Dr. Koshima preferred to take it from the foot. I prefer to take it from the groin or the side of the chest. And as you can see for both sides, if you go full thickness, you would be harvesting the lymph nodes. However, if you go superficial to the superficial fascia or the scarpus fascia, you can harvest only the lymph vessels and leave all the lymph nodes behind. This is what it looks like. And when you flip it over and look at it under the ICG lymphography, you'll see a lot of lymph vessels. And as I said, no more contour deformity. And this is a procedure that works really well in my practice, and it has nearly completely replaced lymph node transfer. If the patient has solid predominant disease, we treat it as such. We treat it with, well, instead of the classic liposuction, I prefer our own flying squirrel technique. What it involves is following liposuction, instead of leaving the skin behind, we like to trim all these skin excess off. And you can see there's a lot of skin excess. If you leave them behind, high risk of hematoma, seroma, high risk of skin necrosis, high risk of contour irregularity. So following liposuction, if the patient has a positive flying squirrel sign, we perform skin excision. This is similar to cosmetic arm lift and thigh lift in these regions, and we can get, sorry, my phone keeps on picking up, and we can get fairly excellent results. Even patient like this with early elephantiasis, we can produce excellent results. And this is a procedure that's associated with very high patient gratification and high patient satisfaction. So following debulking, many of the patients are so happy. They said, I'm good, I don't need any more surgery. However, if the patient desires the most thorough reconstruction, we offer them lymph vessel transfer most frequently. So this is a patient that you've just seen before liposuction. After liposuction, on the OR table now, ready for lymph vessel transfer. This is immediately following lymph vessel transfer. This is the patient 2 days out, still in the hospital. You can see the leg is so completely wrinkled because the leg was decompressed. And you can see right there, no swelling, no edema at all. And this was only 2 days out. And this is what she looked like before. So last issue, is lymphedema curable? You bet. We're not achieving cure in most patients. However, we are achieving cure is not rare. I reported my first case of cure back in 2012, and since then I've seen many. You can hear it from this patient. Actually, we don't have time to show the entire video. Basically, she's 1 year out. She's no longer in a compression garment, and she no longer has any symptom associated with lymphedema, including swelling. And also the cure, the improvement is also confirmed on ICG lymphography. You can see this patient pre-op, what she looked like, and 2 years out. Now I have 3 minutes left. I'm going to take advantage of this 3 minutes and show you a 5-minute video. So I'll go 2 minutes over my 20-minute allotted time to show you how to get started. This is what I have summarized a trick in how to pick up supermicrosurgery. Thank you, everybody. And I'm now ready to take any question you have.
Okay.
Yes, hello, Dr. Chen, one more time. Thank you for your presentation. I will ask you 2 questions and then we'll go for questions from our attendees, okay?
Okay.
You mentioned in your, yeah.
So I'm also monitoring the chat box. So for people who prefer to not vocalize and prefer to type in their questions, feel free to type up your questions. Hey, ready for your questions?
Yes, Dr. Chen, do you hear me?
Yes, I can hear you.
Okay. Yes, I have 2 questions. My first question is regarding, I mean, you have mentioned in your presentation about how to transform a person as doctor who is doing his microsurgery to supermicrosurgery surgeon. But I mean, what's the borderline? I mean, for example, we have a surgeon who is doing his digital replantation under a microscope. What's the transition point when this person from, for example, who is doing replantation of a digital phalanx can be potentially possible to become a supermicrosurgery? I mean, how he can feel it and what's the transition borderlines?
If you go by the formal definition of supermicrosurgery based on the Barcelona consensus, it's ranging 0.3 to 0.8 millimeters. But that was in 2014. In 2015, we lowered the lower limit to 0.2, and in 2016, we got down to 0.1. We're currently still at 0.1, and now Professor Sakoshima is proposing calling 0.1 and 0.2 millimeter surgery nano microsurgery. So that's the formal definition. In actual practice, yes, from doing finger replants, we know that the vessels can also get pretty small, particularly in pediatric distal finger replant. But the truth is, in the old days, we didn't measure how small the vessels actually were. We just knew that they were quite small. So I would suggest, if you're interested, get a Xinhua micro ruler. Next time when you do a distal finger replant, measure the vessels. And you would be surprised that many of them are actually quite large. Many of them are still in the range of 0.9, 1 millimeter, 1.1. In pediatric distal finger replant, we can get down to the supermicro range. In terms of the feel on our hand, I think there are different types of microsurgeons. There are microsurgeons who handle mostly relatively large vessel microsurgery, such as the deep flap. In US, we have a lot of surgeons whose practice is mostly deep flap breast reconstruction. So deep flap microsurgery vessels are typically 2 to 3 millimeters. So many may start to feel a bit uncomfortable at 1 millimeter. And with a little bit of practice, I think anyone can easily get down to 0.5 millimeters. Once we get to less than 0.5, that's where I see more training will be required. And speaking from my personal experience and also working and teaching other surgeons, from 0.5 to 0.4, each 0.1 millimeter decrease increment takes significantly more training, and it's significantly more difficult. So again, from micro to supermicro, down to 0.5 millimeter, I would say relatively easy. It does take some training, but not a lot. But if you want to get down to less than 0.5, it does take some dedicated training. Most of the LVAs are in the range of 0.1 to 0.6 millimeters. Particularly if you're doing the distal superficial lymphatics, they tend to be in that range.
Okay, thank you. So we have one question in Q&A, you can see.
Yes. Okay, lymph vessel transfer that Dr. Koshima refers to, is it the same as thin flap transfer? Okay, so the lymph vessel transfer that Dr. Koshima proposed was the first dorsal metatarsal artery lymph vessel transfer. And based on that concept, we attempted doing ultra-thin skip flap and ultra-thin Tdap flap. And we found out that, yes, it actually worked. And in my experience, the ultra-thin skip and ultra-thin Tdap work even better than the FDMA lymph vessel transfer flap, because Dr. Koshima's FDMA lymph vessel transfer flap transfer on average 2 to 4 lymph vessels. Whereas if you do an ultra-thin skip flap, you cannot even count the amount of lymph vessels that are in the flap. If you put the flap under ICG lymphography, you'll see it's very enriched in lymph vessels. And it is also in my experience that the response tends to be much more brisk following the surgery.
So before we having another question, I have maybe ask. I have seen your presentation. The main suture which you are using during lymphatic surgery is a 12 nylon, right?
So for vessels smaller than 0.4, I like 12-0. For vessels that are from 0.4 millimeter and up, 11-0 would be okay. 0.5 millimeter vessel, I think that's the borderline. 11-0 and 12-0 would both work. And so I like 12-0 suture. However, I don't like 12-0 needle, the 50 micron needle so much, mostly because the current technology doesn't allow a robust structural rigidity. So the 50 micron needle gets bent very easily. Frequently they're shipped bent. So once you take it out of the package, you need to spend some time repairing that needle before you can start using it. And now we have 13-0 with 30 micron needle. We're still trying to get our hands on the 13-0, but I anticipate that it's still gonna feel like butter. But yeah, that's my preference. 12-0 for anything 0.5 or smaller.
And yes, we have a second question in Q&A.
Okay, I can see that. What imaging technique do I use for vein imaging? For drawing before LVA. So I use any of the infrared vein finder. In my previous practice, I used the device called VeinSight. And here at Cleveland Clinic, we use something else. I don't even remember the name of it. I'm sorry, but commonly used machine is actually not the one that I'm currently using. Commonly used machines are either AccuVein or VeinSight. Both would get the job done. And it's also important to note that frequently the veins that are visualized with these vein finders are not the actual veins used in LVA. The veins visualized with the vein finders are typically too big to be used for LVA. And there are times that it could be that patient is obese, or for whatever reasons, you cannot see any vein markings. In that situations, don't fret. Even if you can't image the veins, know that anatomically, lymph vessels and veins tend to run together anyway. So if you can map out the lymph vessels, you can just plan your incision based on the location of the lymph vessels. On the same token, if you cannot see any linear pattern on ICG lymphography, many people will say you cannot do LVA, and I can speak for a fact that you can still do LVA, and we do that all the time. In that situation, vein marking becomes more important, because since you can't map out the lymph vessels, you can map out the veins, and you plan your incision based on where the veins are. And rest assured that your lymph vessels will run with the veins, and you can still find your lymph vessels that way.
Okay. Dr. Chen, what's your trick for have a bloodless field during your surgery?
So you will find that a lot of the bleeding is dermal bleeding. So before I make incision, I like to use diluted epinephrine. So I would do 1 to 200,000 epinephrine injection, intradermal injection, and you only need a little bit. Inject using 30 gauge needle intradermal, just infiltrate your entire incision. And you don't need to wait, you can start cutting right away. And once you get past the dermis, frequently you will now run into the subdermal plexus. That's another area that you will bleed if you cut into those vessels. But in contrast to the standard plastic surgery, we talked about subdermal plexus in very abstract terms. In supermicrosurgery, under high-power magnification, you will see the subdermal vessels clearly. So you can tease them out and you can control them individually. So you'll have a bloodless field. And then you want to dissect out both the superficial fat layer and the deep fat layer. The veins that we frequently use will be in the superficial fat layer. Sometimes we use the subdermal vein as the vein for LVA. The lymph vessels tend to be just deep to the superficial fascia. So when you open the superficial fascia, frequently you will find the lymph vessels. And as you're dissecting, try to go between the fat lobules. Instead of ripping the fat lobules, try to dissect between the interlobule septum. So if you follow those techniques, then typically you can get a fairly clean field.
Okay. And what type of microscope do you use? What's magnification? I mean, your standard magnification for
So for microscope, my preference actually has changed. When I first started out, when I initially learned from Dr. Koshima a while back, Dr. Koshima at the time told us to get Mitaka microscope, which could magnify up to 50 times. So at the time, he was recommending high 30s to 40 times mag. And most of our standard microscope can only go up to 17, 18 times. So that means we need to buy special microscope for this. So when I started out, I was doing the LVA and other supermicrosurgery flap with 30 times mag. But now I actually prefer about 20 times mag is sufficient. You get a wider field and you can see enough. It's actually easier at 20 times mag. And even regular surgical microscope, you can easily bump it up to 20 times mag by swapping out your eyepieces. So your standard, let's say Pentero 800 or 900 will give you 18 times mag. You can swap out the eyepiece that will get you up to 20 times mag, and you're ready. You're in business for Supermicro.
Okay. So
Any of you currently doing Supermicrosurgery?
No, no.
And one topic that we didn't get to talk about in this talk is Supermicro free flap, which the ultra thin skip and ultra thin TDAP are kind of Supermicro. So Supermicro free flap involve vessels that are larger. So they're typically still 0.6 to 0.8 millimeters. So I think LVA is a great training procedure. The demand for vascular anastomosis is actually higher. You can't because of the concern of thrombosis. LVA, assuming you pick the right lymph vessels, don't thrombose because the lymph will wash the blood off. However, LVA frequently involves smaller vessels. So LVA is a great training procedure. When the surgeon becomes comfortable with LVA, then the next logical step is to apply the supermicrosurgery technique to free flap. And then our friend JP has published quite a bit about supermicro free flap. And I know some Chinese microsurgeons have also published the so-called tiny supermicro free flap. And those are really fun, a lot of fun.
My little bit approach to supermicrosurgery only, you know, when I'm doing distal finger replan, distal phalanx replan, and I don't have a dorsal veins, I need to suture palmar veins. And that's how I just little bit approaching for supermicro, but still is not.
In fact, the so-called
so we have another question in Q&A. Okay. Yes. Yeah.
Let me just make this comment. I think most of the audience is hand surgeon. Am I right?
Yeah. Right.
So the tiny supermicro free flap, in fact, has much more application in hand reconstruction surgery than in any other parts of the body. In hand reconstruction, it's not uncommon that you have relatively small defect, and you let it heal. Let's say the fingertip defect, you let it heal secondarily, or you do cross finger flap. These are the perfect indication for tiny supermicro free flap. Literally anywhere in the body you can Doppler a signal, you can raise a tiny free flap, and you can transfer it to reconstruct in a much more elegant fashion. No need to bind the fingers. So I think we are witnessing a paradigm shift right now. I foresee that supermicrosurgery will be similar to perforator microsurgery. Perforator flap 10, 15 years ago was still considered relatively advanced, but today it's just the norm. Everybody performs perforator-based free flap. And I see supermicrosurgery going down the same path. And if you're interested in that area, I know the Chinese microsurgeons have, this may be a bit hard to find because they tend to publish in Chinese and not in English. But Chinese hand, I mean, they call it hand and foot surgeon. Professor Wang from Jinan, those of you who are part of IMC, Professor Wang from Jinan has extensive experience, and he's also he's a hand and foot surgeon. You certainly can talk to him. Okay, getting back to your question. Okay, so anonymous attendee asked, how important are ultrafine instruments for someone starting off trying? Okay, this is a very important question. So really what we're talking about are forceps. You need, your forceps should be smaller than the blood vessels or lymph vessels that you're trying to handle. And the standard microsurgery forceps have 0.3 millimeter tips. And I've just told you most of the LVA range from 0.1 to 0.6 millimeters. That means if you're using regular microsurgery forceps, you're going to have a hard time doing advanced supermicrosurgery. So if you, I would recommend 0.5 millimeter tips for your forceps. Not 0.5, sorry, 0.05 millimeter tips or 50 micron. And right now, the only manufacturer, unfortunately, we don't have a lot of choice. EMI is the only manufacturer that manufactures titanium supermicro forceps with 50 micron tips. There are many other vendors such as SMT, Synovis, GEM would offer the so-called superfine line, but their superfine line forceps have 0.1 millimeter tips. That's certainly better than 0.3 millimeters, but not as good as 50 micron. So that's one thing. Another consideration is the length of your instrument. You want to go short. You want to go as short as you can go. The other day, I had to do an LVA using deep flap microsurgery instruments, and that was painful. Deep flap microsurgery instruments, forceps are long because we're trying to reach into the chest for IMA. The longer your instruments are, the less stability you have. The shorter it is, the closer your grip is to the business ends or the tip of your instruments, the more control you have. So try to go with short instruments, and the vendors sometimes offer you customization to move your grip closer to the business ends. So these are the considerations. Definitely dedicated supermicrosurgery instruments are necessary. If you're considering purchasing these instruments, make sure that you train your instrument processing people, train your operating room processing people, or they will be damaging your instruments and you will be replacing them every month. So in the beginning, probably keep these instruments with you, wash them yourselves, and only hand it to them securely in a box for them to sterilize. That's very important. We learned this the hard way after spending a fortune. Next question is Dr. Anka Oprescu. Is LVA useful, doable for head lymphedema? You bet. For head and neck lymphedema, well, head and neck lymphedema most frequently do have a favorable prognosis, meaning you can treat many of these patients without surgery because the head and neck are constantly being elevated. And now we know, as part of the pathogenesis of lymphedema, it's after the initial injury, the persistent ongoing lymphatic hypertension caused ongoing injury to the lymphatics. So when you elevate the body part, you drop the lymphatic pressure. So head and neck being constantly in elevated position tends to have a lower incidence, has a favorable prognosis. So before we talk about surgery for head and neck lymphedema, you want to team up with your therapist and make sure they have an effective program set up for head and neck lymphedema. Head and neck lymphedema is frequently neglected, similar to penile and scrotal lymphedema. That's another neglected area. So all things considered, we see about 20% of the head and neck lymphedema patient needing surgery. 80% will recover without the need for surgery, or many of these patients just passed away because so many of them had advanced head and neck cancer. So for those 20% of the patient, now you're thinking for yourself, do I do LVA? Do I do lymph node transfer? Do I do lymph vessel transfer? If you think about it, face, head and neck are aesthetically important. This is a highly visible area, cosmetically sensitive area. So if you transfer a lymph node or a lymph vessel flap, you're adding tissue to the head and neck region and it's deforming. Particularly lymph node, it's a bump, it's not a patch. So in general, we try to treat head and neck lymphedema patient with LVA whenever possible. We strongly prefer LVA over the transfer procedure for head and neck lymphedema. And mapping of lymph vessels in head and neck, that's another topic. You definitely can map out the lymphatics in the head and neck region, identify where the obstructions are, identify the functioning lymph vessels, and then perform LVA effectively.
Okay, thank you. There's another question from Dr. Akshay. Yeah.
Okay, I see a question from, yes, Dr. Akshay Deshpande. Are there any supermicrosurgery courses conducted in our institution post-COVID? Yes, so at Cleveland Clinic, we always run observership program prior to COVID, so people can come in as observer. As far as formal training, that is something that we're working on. We currently already have microsurgery fellowship. That's a year-long microsurgery training. We are discussing starting a formal supermicrosurgery or lymphedema fellowship, just because we certainly have significant case volume to support that. And so that is in the work and post-COVID, I mean, right now our observership program is not open yet, but following COVID, when the travel restriction is lifted, we will resume the observership. I think for many of the experienced microsurgeons, I think just from the information and from the webinars and studies, papers that are available out there, I highly recommend that you start trying it on your own and using our chicken thigh simulation model. And also recently I have, I didn't publish, I posted on my Facebook that if you have a nice cell phone with nice camera, it actually will give you sufficient navigation for you to practice supermicrosurgery at home using chicken thigh. You still need the instruments, but for microsurgery instruments, you can actually use the ladies' eyebrow tweezers. They actually work just like our number 3 and number 5 jeweler's forceps. And I use those as a needle holder for supermicrosurgery. So there's a lot that you can do at home. You may still want to have a supermicrosurgery 50 micron forceps if you want to practice at home. You can use your cell phone, use chicken thigh, and just go for it. It's definitely doable. Anyone can do it.
Okay, so we don't have any questions more, right? Yeah.
All right. That's wonderful.
Okay, Dr. Chen, thank you very much for your time and for your lecture. We actually had 130 registered persons, participants, but still online only 32. Maybe we will see and watch your presentation offline. We will upload it on our server. But anyway, thank you very much for your time, for your lecture. It was very nice and very informative lecture.
Well, I hope that supermicrosurgery and lymphatic surgery takes off in Russia and in your institutions. We definitely need more. So as I said, these are two separate topics. We need more lymphatic surgeons. We don't have enough. And the more people that join us, the better off for this patient population. And also, the more people who join us in helping this patient population, the faster we accumulate our experience and the faster we move forward. So thank you very much for the invitation, and I enjoyed the exchange of ideas. And let us know, keep us posted. Any question, any ideas, anything we can do to help you get started, or new ideas, new observation, please share with us. We're learning from each other. Thank you very much, and take care, everyone.
Thank you very much,
safe.
and take care.
All right,
Bye-bye.
bye-bye.
Yeah, bye.